The first thing I think we should talk about is cultural issues. If we're going to deal with the Asian patient, we have to understand the Asian patient, and that could be a big barrier. If you look at a lot of times people that are recently immigrated or are still living abroad, a larger nose is actually associated with good fortune. I remember doing a chef for Rhinoplasty, and he was so excited because he got a raise afterwards, and he thought that it was associated with his Rhinoplasty. And the other thing is large nostrils, especially the anterior position of seeing the nostrils, can be considered money flooding out. So that's oftentimes, you've got to look back and find out what the motivation is for the patient having rhinoplasty. So unlike what Dr. Nass was talking about also, I think we're moving more towards some ideas of preservation of identity. And when I look at the nasal height, we usually use the superciliary crease as our junction of where the radix should begin. And I think it should be a little bit lower toward the mid-pupil, something a little bit lower to be more conservative. And the tip not being overly projected, not to match the facial features. So I used to use silicone implants, and I'm going to talk about some of the evolution of my thoughts. The reason I don't use silicone implant anymore, I think a lot of things are quite obvious, is that it's quite palpable, it's hard, it doesn't really contour the tip very well, there's problems with erythema abnormally, a shrink-wrapped appearance, and occasional infections. And unlike Gore-Tex, the weight of the material can lead to shifting distally. Here's a distal migration from Vietnam, and you can see that I actually had to do a reconstruction to the hole there and then rebuild the bridge with Gore-Tex and the tip with a tip graft. So, interestingly, fat, does that work? I do a lot of fat grafting in my practice, and I don't advocate fat as a method to perform rhinoplasty. But it is interesting in looking at it. I really undersell this as something that could enhance the nose, but I think it's interesting as an adjunct, especially if they're going to do fat grafting, if they've had a prior rhinoplasty or they need a little bit of augmentation, especially for an Asian that has a pretty flat face. If I start building the cheeks, especially into the nasojugal groove, my concern is the fact that I can wash out the nasal bridge. So I will go in there and just put a few drops of fat in with obviously patient consent, but there isn't a huge retention. This is an example of a lady after a facelift fat graft about 6 weeks post, and you can see that she's had fat placed into the upper portion of the nose where there's that little bit of a over-resected top portion of the nose and maybe a slight inverted V component to it. This is 6 months out, showing that it's retaining pretty well, and this is 14 months out with probably a little bit of resorption of it, but holding decently well. The photo on the top is just showing how I match out patients' old photographs. So but I really don't sell rhinoplasty with fat. I don't think it's consistently there, but I do it if I'm already doing a fat graft with a patient and they would benefit from it, especially with a very thinned out skin from probably previous aggressive rhinoplasty. Silicone injections, I think, work for minor touch-ups. I have done it for some very modest bridge augmentation. It's not great for the nasal tip. This is an African-American rhinoplasty I did with a tip-plasty, and then she wanted some more dorsal augmentation. I did just a few drops of silicone into her bridge. This took me about 3 months of putting about 0.15 cc's per time and slowly building it up just to create a little bit more balance with the bridge. Again, that's an injectable rhinoplasty. Radius I don't use anymore, only because I have silicone as a resource to provide something more durable. But I did do radius, and I was seeing longevity for about a year to year and a half. I think it's a great product for people that are not so inclined to use silicone as an injectable product. And I use that for the bridge and then cartilage tip grafting for the bottom portion. I use an open approach. I used a crimped flat SAM sheets, usually between 2 to 4 sheets, to achieve what I want dorsally. And then a tip graft, but it's just basically a cartilage graft to the tip. And the other thing I just caution you about is if you're going to do any kind of dome binding suture and they have a wider nostril show, you want to be careful with exposing the nostrils as the rotation goes up. So if you don't do an alar base reduction or something to compensate for it, and even if you do, the concern is that you just show nostril, because Asians are very obsessed with showing nostrils for sometimes some of the cultural baggage that may be associated with that. And another patient here using the tip plasty with the cartilage and the Gore-Tex stacked sheets, and again achieving closer toward a mid-pupillar elevation of the bridge. There's a book that I wrote with Dr. McCurdy that talks about some of the techniques that I use, and it was translated in Korean about a year ago. And so just some general conclusions is think about some of the cultural issues and just do a little investigative work into the cultural issues before you delve into the aesthetic portion. It may carry a larger portion of the motivation that you may think of, especially for people recently immigrated here. And just be wary about the dome binding suture in terms of revealing too much nostril show for a patient. And just consider preservation and not necessarily westernization in terms of aesthetic goals, but obviously you have to be on the same page with your patients. Thank you very much.